This is our regular monthly session for the LabCoP, and today we have an exciting topic as usual. My name is Anafi Machakam, and I'm excited to be your host today. Today we are tackling a very important subject, a subject that is key to this community of practice, and that is monitoring and evaluation. It is so important, particularly at this moment where we are trying to expand the focus of our community of practice beyond HIV. We acknowledge we have used HIV as an entry point, and all the best practices and improvements that we make, we acknowledge they also can trickle down to other diseases. We have also seen ourselves engulfed with the COVID-19 pandemic. And as we have seen in our successive assessments throughout the duration of our engagement so far, this area continues to be one of the key challenges that we face. So in order to do that, we have dedicated today's session to try and look at what is it that we can do and what is coming up with what we are calling the sub-community of practice. I would not want to preempt the contents of the session today, and would like to leave that to our esteemed presenters, in the name Michael Waweru, who is our M&E technical support lead at the LabCoP and at the ASLM. Michael will be joined by a colleague from Kenya, Faith Ngari, who is a program officer in the National AIDS and STIs Control Program in Kenya, who are also going to give us their perspective from Kenya. This will be a 1 hour long session as usual. That will be made up of 2 presentations, which we think will take us into, I think, the first 30 minutes. Thereafter, we shall take questions and comments as usual, and keep them coming through into the chat box, and we shall take them after the presentations. Let me hand over to Michael to take us through the first presentation. Michael, over to you.
Thank you, Anafi. Good morning, good afternoon, and good evening, everyone. I'll just dive straight into the presentation. I hope you can see it. Now, if I go straight, that's basically the outline of my presentation. I'll highlight some few things, some new definitions here and there, the rationale on why we are doing this, the overall summary of what M&E sub-community of practice is about. We'll do a quick overview of the VL cascades, viral load cascades, and basically the session that we are planning to have when you'll be going out into trainings and the projected out timelines. I included this slide here basically for the purpose of, I appreciate probably a number of you might not have interacted with M&E or what we call monitoring and evaluation, and I thought it would be nice to give a general introduction on what is M&E all about. When we talk about monitoring, basically we are saying it's basically the way you routinely report your data so that you can check on how well implementation and performance is going, and tend to be routine. So it's the day-to-day tracking of progress. Evaluation, on the other hand, tend to be periodic. You're checking the extent to which the outcome are being met, and if you can attribute the changes that you are seeing to the program or an intervention. And it therefore follows that a country program need to have in place a mechanism to monitor what they are doing and eventually evaluate the extent to which the results that they're working toward are being achieved. Now, every year, the countries normally conduct their own self-assessment, and those self-assessment touches on a number of domains. One of the areas that they touches on is the issues of availability of data at national level. And from our previous assessment, for example, the one that was conducted last year, where 11 countries participated, it was noted that a number of countries were struggling in responding to getting data at national level on a number of indicators. For example, those people who were not very suppressed and they received enhanced adherence, and those people who, after receiving enhanced adherence, got a repeat test and eventually suppressed. We realized that that's an area that a number of countries were struggling in. Only 5 out of 11 countries reported on those 3 indicators. And again, only one country reporting the indicators on those people who was suppressed, who have been referred to less intensive model of care. And then 7 out of 11 countries did not reported that they didn't have a very clear monitoring framework for viral load. And therefore, these findings, and in consultation with the countries, it was felt that there was a need to establish an M&E sub-community of practice so that we can address those gaps that Anafi has highlighted and that were very clear from the country own assessment. And in collaboration with the ICAP, CDC, and WHO, ASLM developed some curriculum that countries can tap into, and this curriculum will be implemented for a period of time. No, not now. And then the way this thing is supposed to be structured is that the country team will nominate participant who will be participating in the M&E sub-community of practice. And the expected outcome out of this is that we are going to improve the dashboard that are existing. At the same time, the country will update their M&E framework. And we say that M&E plans are needed to measure the success of a program, as I've just highlighted, because we need to know what is going on at the various levels, especially the clinical outcomes that are for the people living with HIV. And I want to emphasize that viral load is only an entry point. And in the current phase of the project implementation, we'll be incorporating other areas beyond viral load. So the map on the right basically shows the country the country where we are currently implementing the LabCoP project, and the intended audience or participants for this M&E sub-community of practice. It is envisaged that we are going to have 3 to 5 people, members, representing both the lab and the clinical team. And the reason that's why this is extremely critical is that we can achieve that, what we call the clinical lab interface. And this community of practice is not a standalone, but it will be subsumed within the greater LabCoP country team. So it's just a support team. They become a part of that team. It's not a standalone sub-community of practice, but basically the country will have a sub. If I use the kind of mathematical whatever, you can think of it that the LabCoP bigger country team is the universal set, or the M&E sub-community of practice is basically a subset within there. And with this team, then we'll go through a training, and the training is intended to provide some guidelines and consideration to the country team as they either develop, or they are reviewing, or they are strengthening their laboratory M&E system. And we are using viral load as an entry point, but the whole focus is the larger laboratory M&E system. And it is expected out of it, an M&E framework will be developed, roadmap for development or review of national level dashboard, again, will be developed. And out of all this, you're going to have increased availability, access, and use of data at all levels for decision making. The training will take about 4 months, from January to April 2021, and will be conducted in collaboration with various partners. And there will be a lot of South-South learning, where countries will be learning from each other, looking through and seeing which country has sort of strength that another country can learn from. What can Nigeria, for example, borrow from South Africa, or Uganda for that matter, or Congo? So they will be encouraging a lot of South-to-South learning in that period of implementation. And when I talk about the viral load cascades, this is what I'm talking about. A country needs to be able to track from the number of people living with HIV, how many of those people are getting the test when they need one? How many of them are very suppressed? And if you're very suppressed, you need to be moved to a less intensive model of care. And there's a lot of work that is going on there within the sequence. That's the first cascade that a country needs to be tracking at the various level. And the second level, the second cascade is, if you are not suppressed, you need to be put on enhanced adherence. Who is getting to enhanced adherence and completing it? Who is getting a repeat viral load testing? After you are very suppressed, who is moving to a less intensive model of care? And if you're not very suppressed, who is getting a repeat viral load? And when you get a repeat viral load, if you're not suppressed, who is moving? Who is getting a switch of regimen? And if you get a switch of regiment, who eventually get to be suppressed. These are the critical cascades that are extremely important for us to track. They're not the only one, but these are critical cascades. And if you can, all right. So I was talking about the various sessions that are planned for this, and we are going to have a number of sessions. We do an overview of M&E. We look at the various indicators that are used for scale-up of a very program, and the issues of country assessments and how the country assessment finding inform the work planning. Move on to the next slide, Anafi. And then we appreciate the impact that COVID-19 has had on viral testing. Again, there will be a session covering that. We'll look at how establishing of lab management, information management systems, the issues of dashboard, visualization of data. We cannot talk about data without the quality of data, and therefore there'll be a section that detects the issues of quality of data. And finally, we will be having a session on evaluations. Next slide, Anafi. So in terms of timeline, the current phase that we are in, we are expecting that the countries will be nominating their members. And during that time, then the country will do an assessment of the M&E for viral load. This assessment is geared toward to learn where the country is at, and it will be informing the plans and the way the country-specific plan, so that when we go to trainings, the training will be tailored to meet the country-specific needs. And then between the month of November and December, then the result will be shared and the country-specific plans will be developed. And then from January to April, we're going to have the trainings and the implementation of the activity plans. And finally, come to the month of May or June thereabout, you're going to have a face-to-face meeting whereby all the M&E sub-community of practice members will be brought together to share their next course of plans and agree on the course of action moving forward. Now, I want to emphasize on the country assessments, because the country assessments are extremely critical, because it's from them that, as I've said, we'll be developing the country-specific plans. And beside that, Kenya, the next presentation that is coming from Kenya will be basically showing where they are at, which is in line with the country assessment. So thank you so very much, and I'll hand you over to Anafi and finally Faith. And sorry about the interruption with the internet.
Thank you, Michael, for the presentation. And we're glad to have you back. Colleagues, keep your questions and comments coming through. And after this introductory presentation from Michael, we'll get a dive into the Kenya experiences, which are going to be presented by Faith Ngari. Faith, over to you.
Thank you very much, Anafi. Good morning, good afternoon, and good evening, colleagues. Allow me to share my slides. I will just go straight to the presentation, and I'm making this presentation on behalf of the M&E subcommittee team, and the members have been listed there on my first slide. We are 6 of us that are put together this presentation. In regards to the outline of my presentation, we're going to look at the country statistics, the lab networks, data management tools, EMR implementation, then we'll have a summary of M&E for viral load, and then the system's strengths and challenges. So just to give you a background in regards to the burden of the disease in Kenya, we are currently having a prevalence of 4.4%, which is greater in women compared to men. We have 5.7 in women and 3.1 in male. Our estimated people living with HIV is about 1.5 million. This is all ages, majority of them being adults above 15 years of age, which is about 1.4, and about 106,000 being below 15 years of age. If we look at the new infections, we can see that we get about 41,000 new infections every year, majority again being among the adults and the children. But of importance to note is the infection among the adolescents and young people, which is about 35% of the new infections that are occurring to the country. So this is a special population that we are keenly looking into. So if we look at our current performance in regards to the 90-90 cascade, and why I put this here is because we need to look at the third 90, which is our indicator of interest in this presentation. You can see in regards to the identification, we are currently doing about 86.9%. In the second 96.5%. And the viral load suppression, we are about 91%. This is overall. Again, good performance among the adults in the 390s, though we have not been able to hit the 90% mark for the first 90, but for the other 2 consecutive ones, we have been able to achieve. Of importance to note is the performance among the children, which is still wanting, and the figures are way below the cutoff point of 90. For the third 90 being 91, the second one 77.9, and the first 90 70.2. So in terms of testing coverage for our laboratories, we have about 8 labs that are actively involved in the testing for HIV and also for viral load testing. And from what you can see from this map, the color code matches the area where the respective lab is offering the services. So you can see majority of the tests are under the Cambridge Nairobi laboratory. However, much as it's covering a very wide scope, these are not very high. I mean, the disease burden is not very high in these counties. Majority of the disease burden is to the western part of the country, and you can see we have quite a number of labs that are able to cover that area of the country. This is just another map showing our 6 labs, our 6 main labs, and the placement in regards to access. You can see majority of them again are where the disease burden is mainly high. However, we have about 4 labs that are within the central region covering Nairobi and the central part of Kenya, and 1 major lab that is placed at the coast of Kenya that is covering the coastal region of Kenya. So for data management, we have a set of tools. We have tools that are facility level based and others that are testing labs based. For the facility level based tool, we have the clinical encounter form, which is like the key document in regards to client management. And this form is filled immediately you are enrolled into care in the HIV care clinic. This form contains all the information in regards to the patient, and even for facilities that are offering the services electronically, they have this form being digitized, and it is just a replica of the hard copy form. Then we have the viral load testing form, which is usually the request form filled by the clinician and is sent together to the lab where the sample collection is done. But in addition to this, we have the facility sample tracking logbook, which is again kept by the facility to facilitate them track the movement of samples so that they can be able to track when there is delay. Then at the testing lab, we have the Hub Lab VL sample and tracking logbook, again also used at the testing labs to just monitor the movement of the samples. And where there is rejection, there is a form that is filled at the lab level, and it is shared back to the facilities where the sample did come from. So this is just, I'm sorry, I guess you may not be able to see clearly, but just to mention that we have also gone ahead and digitized part of our facilities, and they are all operating on the electronic medical record. And what happens is that at the entry point, you can have either a digital platform or a paper record. However, the content is all the same. So once you get through the HTS application, your data is again pushed into the electronic medical record, and this data is sent to a repository, which is called the National Data Warehouse, where we have all our client data being stored. And then from the national repository, we are able to derive dashboards that are going to show us our performance. And from these dashboards, we use them for data, for policy making and for planning, and also for reference to just observe how the various categories, be it the facilities, be it the subnational level, how they are performing. And then for also facilities that have paper-based at the testing area, they are also able to transmit their data into the electronic medical record. And again, it follows the same process into the National Data Warehouse, and then we can be able to execute this for analysis and use. However, we still have facilities that are 100% paper, and this is again reported through the National Reporting Platform, which is DHIS2, currently called KHIS. In regards to our dashboards, we first talk about how we get to our dashboards. We have an organogram for data management. So the two divisions, that's the National AIDS and STI Control Program, together with the Health Information Systems Division, are all convened through the SIRI unit in LabCoP to be able to advise or guide the viral load subcommittee of experts. And that is how we get the expertise from all the sections to make sure that we take care of the requirements that are either needed by the M&E section, the care and treatment section, and also the National HIV Reference Laboratory. We have made milestones in regards to the VLEID dashboard, thought of back in 2010, when the SET team sat together and came up with the idea of digitizing the system. And at this time, they were just thinking about how to take care of the logistics aspect of viral load and the turnaround time. And so in 2012, they developed the initial VL dashboard that majorly supported the logistics and turnaround time. But again, with time, the demand grew. And now with the involvement of the care and management team and also the National HIV Reference Laboratory, there have been several revisions in 2015, 2016 that have been done to ensure that we incorporate the programmatic aspect, which has been led to better results, as you will see in our dashboards in the next part of my presentation. And in 2019, we have been able to integrate our aggregate data reporting system, that's the DHIS2, together with our EMR. And hopefully we are going to have create a facility level registry where we can be able to pull and push data for better care and management of our clients. So these are just some of the examples of the dashboards that are available. And we narrowed that down just to look at the viral load dashboards. So what you can see on my left is a dashboard that is indicating the number of active patients, how many are eligible for viral load, and how many did actually turn up for a viral load test, and how many are suppressed. And then down there, you can be able to see the various aspects of the viral load testing, which is either categorized by the facility per the regimen the clients are on. Then this is also just another aspect of the dashboard from the EMRs. And what you can do is if you click on the number that shows you total active clients, it gives you, it generally generates what you want to see. So if you click on the children aspect, then you're able to see how are the children performing. If you click on the adults, the same, and the same for the adolescents and young adults. So for the viral load dashboard, we have again the separate dashboard that does exist on the system, and it basically tells us about the operations of the viral load work. So you can be able to have a summary, then you can narrow down to your area of specific. You can either go to the subnational level, which can be a county or a sub-county. You can get to the facilities. You can see the partners who are supporting you, and you can also be able to see the trends over time. And the good thing about this, it is patient level based. So you can be able to, again, download the patient level data, which is de-identified, and further make analysis that should meet your needs. Then the pie chart is just indicating the number of tests that have been done. And it also narrows down to give us the total individuals that have been tested. And we use the what we call the CCC number to identify individuals. We have a format of writing it down where we use the master facility code of the facilities and 5 digits that are serially given by the facility at facility level. So every master facility code is unique to a facility, and hence it enhances the margin of error in regards to duplication of patients. So you can be able to see how many tests were done, how many individuals were tested, how many were suppressed, and we can also be able to further classify how many got below 1,000, below 400. So that is what is being shown on my right. I'm sorry, it might not be very clear, but we will share the slides after this. Then further to that, you can also observe the trends of how you're doing your testing. So you can be able to tell which month you're performing very well. And if you want it again indicated by gender and by age group, this can also be availed through the dashboard. So again, additional to our viral load dashboard, we have been able to use it for further analysis. In this era of COVID-19, the same path that is used for testing for viral load has been used to test for COVID-19. And from the system, you can be able to visualize some analytics in regards to testing for COVID-19. And we've also been able to create and manage a worksheet that is used for testing and return of results, and also be able to monitor commodities. Other areas of support that the team working and in the lab has been able to offer is that we have the data analytics personnel who are able to do analysis through the same system for COVID-19 testing. And also we have the IT staff who are supporting in regards to enhancement of the system to capture more information beyond viral load. And also we can see that the form that is being used for testing of COVID-19 has been derived from the form that is used for viral load testing. So it's just minimal alterations and additional modules into the system, and you can be able to do any other test other than just the viral load test. So more to that, we also have efforts of tracking differentiated care. So we also have aspects of capturing data on differentiated care model. And from it, we are able to do analysis and trend over time to see how we are picking up in terms of DSD. So this is just a screenshot of part of what we've been able to do as analysis, how many of our clients that are stable in terms of viral load suppression and other aspects of management are already introduced to the DSD model of care. And you can see that with time, it's been peaking, and I believe even by September, the performance is much better, and you can be able to see who's on fast track and who's on the community-based model. So after doing an analysis of our M&E systems and tools, we have been able to know that we have in place the viral load testing requisition forms and the tracking register. We also have in place the viral load results form. And also we are able to have aspects of patient monitoring systems that are active and up and running. And we are able to report to the central reporting platform, which is the Kenya Health Information System, or rather DHIS2. However, we still have a few things pending in terms of coverage, in terms of the laboratory information management system. It is not nationwide yet, so it's still just existing in some areas. Also, in regards to the viral load testing, you have seen that we just have sample networking and converging our samples to the central, or what you call the hub labs. So there is need to increase that. Then in regards to monitoring of the high viral load register, yes, we have innovations that have been put in place by different partners. So we need to come up with a register that is officially out for use for monitoring patients who consistently have viral load being high and they're not getting suppressed. So all these are the areas that we are working towards getting to, ensuring that we have relevant data collection tools in place, and we continue scaling up use of electronic medical records to other facilities. So in the assessment, we were able to discover that we have a bit of what is required for monitoring and evaluation, and I'm not going to read through everything. So I will read areas where we still have gaps. And this, I believe, I've already alluded to in my previous slides. This is areas of monitoring patients who are not suppressed, or patients who have not been suppressed but have gone for adherence counseling and now they're back to their care and management. We do not have means to track that at either, especially at the national level and at the subnational level. But however, the facility level, this is available. As I said, in our clinical encounter form, everything that is done to the client is documented. So this information can be available at the facility level. So what we need to do is to find mechanisms to find this data flowing upwards to ensure we get it at national level. And likewise, for those patients who persistently have high viral load and they are not not getting suppressed, we also need to have a way of aggregating this data and sending it up to the national level. Then the other aspect is the percentage of virally suppressed people living with HIV who have moved to the less intense model of care. It is available. It's now yes available, but not really 100%. So it's still an area that we would like to work on to ensure there is 100% coverage, because what I did show in my presentation is just from the facilities that are able to report electronically. But if you want like a country coverage, we do not have that nationally. So we still have to put a reporting tool in place. Then the other aspect is in terms of real testing coverage and outcomes. At national level and subnational level, we can be able to have the testing coverage because we do have the estimates number for the general population, and we also have the estimated number for pregnant women. However, we do not have estimated number for breastfeeding women and key population, and I believe this is work in progress for the estimates team so that we can be able to generate the testing coverage once we get a reliable denominator. At facility level, across all the types of populations that have been defined, we are not able to get this because we have not been able to drill down our estimates further to facility level. So the strengths, this is just a summary. The strengths are: one, we have a national dashboard. We have remote logging that happens at every testing lab. We have viral load sample networking. So our samples have been mapped to the various hub labs that I have indicated earlier on. And then we have inter-lab program where they look at the quality of the results and the work that is being done in each. Part of the challenges or the gaps that we will need to address is the inconsistencies in documentation. And this is because we do not have a national unique identifier. Much as we have a unique identifier for our CCC patients, I think it would be important for us to have a national identifier cutting across the entire health system. And then we do not have a longitudinal tracking of viral load. As I said, again, we are integrating our system so that one system can be able to push data to and from the other for purpose of longitudinal tracking of our patients. And then tracking of absolute turnaround time is also still a challenge. It's not very well defined, and we still have aspects of data quality, much of which has been as a result of lack of the unique identifier. So I will wish to acknowledge our colleagues from the Ministry of Health, that's through the National AIDS and STI Control Program, the National HIV Reference Laboratory, county governments who we work together with, the support that we have received from USAID, DOD, and CDC, and our technology partners who have assisted us in going electronic, that's Clinton Health Access Initiative, CHAI, Palladium, Kenya HMIS2 project, the University of Nairobi Health IT project, and then we have a series of service delivery implementing partners who are working together with our county governments at the subnational level to ensure that work is executed. And definitely, finally and not least, we want to appreciate the African Society for Laboratory Medicine for supporting us and enabling us to share with you our experience. Asanteni sana. Over to you, Anafi.
Thank you once again, Faith, for the wonderful presentation. Asante. So it's time we need to now get into the question and answer segment. And as usual, we shall take questions from the chat box. Please keep them coming, and we will be taking them one by one as they come. Let me take the first one from Lawrence Kachule from Malawi. Lawrence says, does Kenya have a mechanism of tracking recollection of samples for infants whose DBS were rejected by the testing lab in the first place? I think he wanted to follow up on that. And this is directed to you, Faith.
Yeah, thank you. Could we pick a set of them and then we can respond to all of them? Like first five?
They are mixed up, so that may be a little bit tricky, but maybe whilst you are answering that, I'll try to get them ready.
All right, so thank you, Lawrence. Yes, we do have a mechanism for tracking what has been rejected. And I said we have a form to show what has been rejected and the reason for rejection, which is shared back to the facility that generates the sample. But I think more to this, I can request Nancy or Leonard, who's part of this, to add more inputs to the response. Nancy and Leonard, one of you.
All right, let me make Nancy and Leonard co-host. Maybe whilst they are coming up, I saw Lawrence has asked quite a number of questions, and I would like to call upon him to maybe probably ask the next question that he has posed. And he has also expressed interest in learning more from Kenya. Lawrence, are you there? Lawrence? All right, I seem not to be able to pull out Nancy, and please go ahead. Okay. I think maybe the other question that
is Kenya using?
Go ahead, Lawrence.
Okay. The other question is Kenya using conventional PCR method for EID and viral load, or they're using near point of care, which is a gene expert? If in case they're using a gene expert, what are the operational challenges in the integration? Because a gene expert is a polyvalent testing platform. So we want to learn, because here in Malawi, we have also rolled out the use of a gene expert on targeted viral load and EID to close to 50 sites. So these are sites that are doing more than 2 testing assays on a gene expert. So we want to learn from Kenya, their experience on the issues of utilization of the machine, and the other operational challenges that they are facing in the integration itself. Over.
Thank you, Lawrence, for that. Faith, any responses or remarks?
Yes, I had. Okay, he has asked if we're using Gene Expert or POC for PCR for EID. That's the question Lawrence has asked, and I will request Leonard or Nancy to respond to that.
All right. I seem not to be able to find Leonard and unless they are using different names.
Okay.
And Nancy. All right. Whilst we are trying to find them, I will take the next question, which is from John Mapulanga, who wanted to know, where are you hosting this data? You presented quite a number of things around the dashboard. He wants to know, where is the data hosted?
All right. In regards to data hosting, that one I can respond to. We are hosting the data in a central server that is being held at the national level. For the EID and BL system, the data sits with us at the National AIDS and STI Control Program. So what happens immediately, it's keyed in from the hub labs, it is reflected to that national data center. And then from there, we are able to do our analysis from there. Then for the national data warehouse, again, it's still a subset that sits at the data center that sits within the National AIDS and STI Control Program. And we do also host the individual data that comes from the EMR. So what I said, we have not been able to link these two databases, and what we are currently planning on is creating an interoperability layer that can be able to first work from facility level. So once you get it working at facility level, then certainly once it gets to the national data warehouse, it will already be linked. So you'll be able to get a complete set of data either from the ELVID system or from the electronic medical records that sits at the facility.
Thank you once again, Nancy. And O'Brien Nalubanda says, this dashboard looks more like the eLabs one that is operational in Zambia and other countries like South Africa. I think this is just a comment. Maybe you want to react to that.
Probably one of the things you realized is these things grow from country to country, and there's a lot of experience sharing. And even for the partners and the stakeholders that we work with, they probably borrow this from what they have done in other countries. So yes, our dashboards could be looking the same.
All right. I was trying to look for some colleagues from Kenya. I found, I think, a few, like Franklin, and then there's Kenneth. Kenneth, if you're there, please feel free to chip in. Are you there? All right. I'll try to unmute him. Okay, that's fine. Looks like we're having challenges in getting colleagues from Kenya. Let's move on. There is Amara Uche, who has also posed a question around the turnaround time of EID results. Are these being retained in a timely manner? I think she wanted to know from your dashboard whether you are able to track that as well.
Yes, we are able to track the turnaround time from the dashboard, but again, as I said, it's not very reliable because we are only able to get information into the system from the lab level. So we are only able to know the turnaround time from the time of testing to the time you get back your result, to the time you get back your results. So we still have a gap in regards to the request time until you get back your results, because that is still not linked from one system to the other.
Great. I think that's a very important point to really make sure we work around that lab clinical interface. And hopefully these are some of the things that the sub-community of practice can try and see if we can be able to address, particularly with regards to linking that and see the whole cascade. Michael initially, I think in his presentation, presented that cascade, and from the initial assessments that we have done, I think we have struggled a bit to link all that. I also have a question for you, Faith and team, just to share with us, after all this advancement and getting the dashboard and the data coming through, how is this helping you to make decisions? I know you said there could be some gaps, but from what you have so far, how are you able to be using this data to inform our future decisions?
All right, so...
Are you making use of the data?
I know data use is still quite a challenge because if you come around and ask people what sits in these two systems, there's very little that is known, because our key interest of what we really look out for are the main indicators that we collect. So like, for instance, the viral load suppression by gender, by probably the type of patient that you'd like to look at. That one you can be able to look. And I can say this has really been utilized, especially when we are going around the estimates process, because we are able to get data for the different subcategory of patients, and this eventually really helps the country during the estimates process. The other area that has been really utilizing the data that we collect is the planning for commodity, or what we call the procurement process, and also the quantification process. They really rely on this data when you're doing quantification and when you're planning on what the country really needs in terms of commodity. So it is data that is, I can say, yes, it is partially used, but I can say it is very rich database with very good data. I think that really needs to be dived into for better use, but we are currently referring it for most of our areas. Again, we also said for identifying clients who are stable over time, because it is individual level data, you can be able to see the progress of a patient after several tests have been done, and you can be able to classify that client as stable, and you can be able to put them on the differentiated care model. So that's another area, again, where we're able to use the data. So there are aspects of use, but again, there's still more data that can be utilized further.
And thank you once again, Nancy. I think moving forward, there's a question from Mary Akumu, and she says, the presenter mentioned the availability of DHIS2 platform. Have any steps been taken in getting the data hosted in the DHIS2 as opposed to being hosted at the STI program as mentioned?
Yes, the answer is yes. We have been able to, mind you, DHIS2 is an aggregate reporting platform. So what we have been able to do is to create the aggregate form at the back, at each of the systems. And for instance, let me use what we use to report to the national reporting platform, which is DHIS2. We have a tool we call 731. So either of these systems does a component of the 731, which aggregates or does the summary as you would do manually. And eventually, this data is pushed into the national reporting platform, which is DHIS2. So we have made steps to reporting to the national reporting platform, that's the DHIS2, as opposed to just having the data sitting at the specific systems. And in addition to this, for the EMR aspect, now we have the tool embedded at the system. So what you're going to be doing is each facility, once the close of the month gets, then they are able to automatically send that data into DHIS2 without having to go through the manual system, which you've been practicing. So that is something that we're also working towards.
Okay. Thank you once again. And I'd like to take this next question from Yemu K. To send privately. We want to encourage you to send them to everyone in the chat for the benefit of everyone. So Yemu says, how is the Kenya team factoring in the timeliness of completion of the viral load cascade? For example, more frequent testing for pregnant women and follow up after testing the first unsuppressed viral load.
Okay, in regards to testing for the various categories, we have guidelines. For pregnant women, it's usually done every 3 months. And equally for those that are not suppressed, it's immediately you get your results. Again, you have to request for the test to be done. So we are monitoring this. And as I said, we do not have like a tool that tells us that this person has not been virally suppressed for a while. You have to wait for the results to come back to the facility. And then once you get the information again, now you request for the sample again for the client. So we are looking at mechanisms of having something to track the movement of patients who are not virally suppressed over time. I identified that as one of the challenges we currently have.
Yeah, thank you again, Nancy, for that. I think we want to move on. I can see John, I think John Mapulanga asked a question that I might have jumped here, and he's online. John, are you able to quickly unmute and speak?
Oh, yes. Good afternoon. Good afternoon, Faith. I'm John Maplanga from Zambia. I'm trying to see the integration of the true point of care, because in the presentation you had said that Gene Expert is the same point of care, but there are platforms which are true point of care. For example, maybe MPIMA, which is a true point of care mostly found in the limited resource setting. How do we integrate such type of program platforms into the M&E, national M&E framework? Thank you.
Thank you, John. I think it's an important question in terms of when we try to reach that last mile of service, how do we then bring all that information that is there into the national system? Over to you, Nancy and colleagues.
Okay, so thank you again, once again, and thanks for the questions. As we said, our last mile is what we are working towards. If you looked at my second last slide, or the evolution slide, we are looking at how to bring together all the information that does exist in regards to patient care for longitudinal tracking. And this includes the point of care. So if this is yet not accomplished, And the first thing we want to do is to create a national registry, because there is no national registry. And the minute you don't have a registry, then you cannot be able to get information to and from different systems. So we are looking into coming up with a registry. First of all, we want to create a registry at the facility level, and then we can be certain that information is moving to and fro between different systems at facility level. Then once that is up and running, now we will now think about how to have a national registry, which now can be able to have like inter-facility exchange of data. So this is still food for thought, and we are also planning on how to learn how this can happen. It's happening in a few of our sites, which are partner supported, and we want to learn from them what exactly they did. So it is our last mile movement, and hopefully we shall be able to share this probably in 2021 when we have been able to accomplish.
Thank you, Faith, for that. And indeed, some of these point of care systems come with some data management systems that also need to be integrated, and hopefully I think this is something that we can work together. I've acknowledged Kingston as well as Leonard coming through, but before they come through, I just want to raise attention to Farai Kevin Munyanyi's question here, who is talking about he saw a map of the the counties selected and the sub community of practice, the M&E, and I think he just wants to understand how you have selected your country team. And I think this is important. We are also looking forward to the other members to also send us their country teams. But from our LabCoP perspective, we want this to be represented as representative as possible, both from the laboratory side as well as the clinical side, including the civil society, so that we work together for the benefit of the patient. And actually close those gaps that we find in the lab clinical interface. So I think that's a great question indeed. Let me bring in Kingston to ask a quick question. Then Leonard would want to also respond to some of the questions that we have already been posed. So Kingston, over to you.
Yeah, thanks, Hanafi. So I wanted to ask how the Kenyan team has been able to use the remote sample login to track their turnaround time, because I remember the presenter was saying they're able to track from when the results are released in the lab to when it gets back to the catch facilities. But I remember when I was in Kenya about a year ago, I was told that remote sample logging had been implemented in some areas of Kenya. I think basically some part of Nairobi and in some other, the coastal region. So are they able to use it to track their overall turnaround from sample collection down to result return? And have they been able to scale it up? If they have, are there challenges they have that we can learn from? Because it's one of the areas we're actually going to now.
Thank you, Kingston. An important question indeed, and that also touches what we have been talking about. For us to be able to monitor and evaluate, eventually we will start from the collection of data and be able to analyze. So let me hand over to Leonard and Faith. Leonard, over to you.
Okay, thanks. I'm in Faith team, and my response would go to the aspect of how have we, majority of the point of care that we use are near to point of care, but how do we manage to get data from true point of care that are being offered at the patient bedside? And that one, we don't have so many the true point of care, but among the sites that we do have it, we have a mix of a paper-based system that the information is being captured on a paper-based system, but and then later on it's being transferred at a lab level now from the paper-based system now into the lab VL and EID data system. Aside from that, we are also in the process of evaluating the various data system being that comes with a point of care. We have the nodes, and then we also have the data captured system for the GX limbs. And then we also have the data capture system that has been provided by Abbott MPIMA. So we have a study that started, I think, in 6 months ago, supported by CHAI. Once we do the evaluation of that data, we'll also be able to share it with the team. Over.
Thank you again, Leonard. We have reached the top of the hour, and indeed, this is a very important subject that today is just the first day to really try to scope this, but we intend to really go deeper within the community of practice and have country-to-country engagements and working towards identified deliverables, and most importantly, demonstrate improvement in all these gaps that we are mentioning. Even if there are 100, most of these gaps we have realized that they are similar. The only difference is probably the scale in which they are in each of our countries. So I'd like to hand back to my colleague Michael to just give us a few words in terms of how we move forward and see what we can be able to achieve together.
So thank you, Anafi, and thank you, team. I think my closing remark is to encourage the teams to send in their nomination for the participants for the subcommittee of M&E subcommittee of practice, so that we can jumpstart this process as early as January, as you have seen. As we said, we expect to conduct the country to conduct their own self-assessment, so that they can identify the areas of weaknesses and strength that they can share with other countries. So that will be it for me. I'll request every country to remember to nominate the participants so that we can jumpstart this. Thank you so very much.
Thank you, Michael. And Nancy, just quick 30 seconds. Sorry, Faith.
Sorry, that's why I went silent. So I thought able to join Nancy. So for me, is to appreciate the opportunity to share our experience. I believe there is more we can discuss with everyone, and there is also more to learn from all our colleagues from other countries. Otherwise, we really appreciate the moment and the time, and thank you for the opportunity.
Thank you once again to all the presenters and all of the people that participated in this session today. We always appreciate you. It's a platform that we see we are able to share knowledge and experiences, and hopefully we may be able to use whatever we learn here to make a difference. And we're looking forward to this community of practice making key differences, making key deliverables that possibly we never thought would have achieved in the short space of time. But I think together we can do this. And we look forward to, I think, the representation of all the country teams coming through, particularly those LabCoP team members. And we're looking forward to receiving all the nominations from you. I'm going to be displaying, as usual, the code for you to be able to go to the ASLM Academy and be able to download the certificates should you need to do so. Should you face any challenges, we do have a frequently asked questions section that is there. Please feel free to go through, but still, if you are not able to get assisted from those responses, feel free to communicate with our communications department using the information that is and contact information that is given there. Till we meet again, this is goodbye from me. Bye-bye.
Bye-bye.
Hello, bye.